Center. We'll be giving a talk on Friday at noon on functional localization in flux to the neuroscience. It's my pleasure to introduce my colleague and friend, Dan Wilkenfeld, who is associate professor in the School of Nursing here at Pitt. He's also a fellow of the Center for Philosophy of Science, a former visiting fellow of the Center for Philosophy of Science, and also a fellow of the Center for Bioethics and Health Law at Pitt. Daniel was, and in fact still is, a philosopher of science working on issues around epistemology. He has written extensively on understanding and explanation. He also has done a lot of work at the intersection of philosophy and psychology. For a few years, he was working with Daniel Ambrosio when she was at Berkeley before she moved to Princeton. And he published in the best journal in psychology, including cognition and the Psychonomic Bulletin and Review. He also more recently, in part as in relation to his move to the School of Nursing, he has also moved to issues related to bioethics and ethics in the philosophy of nursing, with a special interest in issues related to disabilities and to a political question, an ethical question raised by disability. In this respect, I will mention one of his recent paper in Res Philosophica. The title is Contextualism about Disability, as well as a paper in 2024 in Study, Pursuit-Worthy Research in Health. 3 examples and suggestions, which I think you gave a talk here a year or a year and a half, ago. So it's really a pleasure to have you back. It's always great to see you. I should mention Daniel is also my former postdoc, so it's always wonderful to have people back here. And today Daniel will be talking about moral distress as a kind.
All right. Thank you for that. Sorry. Thank you for that lovely introduction. So first of all, I should apologize for the branding. Apparently, I'm no longer supposed to be Pitt Nursing. I'm School of Health Sciences. So pretend that's what you see up here. Okay. This is how things go in bureaucracies. We change how we're supposed to identify. So I am now School of Health Sciences with Pitt Nursing somewhere in there. But that the shift to Pitt Nursing, as Edward mentioned, is important to contextualize this particular talk because it was conceived of primarily in the context of nursing ethics, in the context of nursing philosophy, and in the context of just working with my students. And most of them have practiced as bedside nurses and seeing the issues that they relate to most. And one thing that comes up over and over again is this issue of moral distress. For totally mercenary reasons, I decided to present it here so that I could get a cool Phil science angle. So I'd have my own little spin on it. But so hopefully you all can really help me tease out some of the more theoretical implications of this construct / concept. For those of you who don't know me, which I think I know about half of you, my PhD was in philosophy of science under Stuart Shapiro, Robert Kraut, and Richard Samuels, and Declan Smithies. Don't want to leave anyone out. So this is my first love. But now Edward already listed what I do now, so I don't have to repeat that. Also should flag, I probably won't make eye contact. I have been diagnosed as level 2 autistic. Please don't take offense and try to follow the pacing and the stimming. Sorry about that in advance. So I'm going to just throw a bunch of cases on the board because these are the sort of things that you'll see in bioethics textbooks, you'll see in nursing ethics textbooks, and you'll see when you talk to practicing nurses. And also just because this is the way the dialogue is structured, it's primarily around these sorts of cases. So, and we'll see if you can detect how many patterns there are. These cases are definitely going to be similar in some ways and maybe different in other ways. And part of what I'm going to want to question is how we should group them. So I'm starting off with ones that I'm pretty sure all go together. So I never know whether to read these out loud or just leave it to you. I'll just leave it to you, I think. Can people in the back read this? Okay, so I'll just leave it to you. You don't have to hear my voice that much. Okay. Conversely, the silence is a little awkward. So I don't know which way to go. So this is a standard 101 case where you put veracity, again, the need to tell the truth, versus it along with maybe autonomy, people's ability to self-control, self-determine, versus beneficence, wanting to help people get the best results. This is a fairly classic dilemma. We teach it in 101. I'm actually not sure where it comes from. This one I do know where it comes from. And so the one you see on top, that's the sort of thing that's sort of hot button. You talk about a lot in 101 to get students thinking. This is the sort of thing that my colleagues encounter every day. I will read it. I didn't like the silence. Patient misses 3 appointments. By practice policy, they should be dismissed from the practice. But you could get around the rules. You could include them. This is the sort of thing nurses face day to day. Especially those who run their own practices. Other providers face day to day. When do you bend the rules? When do you break the rules? The rules are there for a reason. Hard to say. This one I like just because it's so weird. And this one I did happen while I was on the clock for helping people with their ethical cases. So a patient had an advance directive saying he didn't want aggressive treatments. That's probably better than what I have up there. But now he's saying he wants to speak to his wife. Not clear what that means. We call her on the phone. She's too drunk to talk to him right now, according to her. But she wants us to keep him alive until tomorrow using aggressive measures. So there's a lot going on here. Don't know what to make of it. And so again, this actually happened to a friend who talked to me. And what do? You have autonomy. You have advanced directives versus what they're saying now. You have ambiguous data. These are hard cases, I think. There's some other different, well, we'll see if you think they're different hard cases. So suppose you have a patient with a terrible prognosis and intense suffering. You have seen many such cases and know that it's time on your read to stop aggressive measures and transition to comfort care, which is very different from stopping care, which is how people sometimes call it. But no, it's a different type of care. But the patient's son, who has power of attorney, sees things differently and insists on aggressive measures. And this is so common. Every time I ask students to write a paper about, like, tell me about an ethical issue, 40% of them about, hey, this is some variant of this is what happened to them. Another one that I find a little more disturbing, but this is absolutely real. Patient is suffering intensely and clearly going to pass soon. At some point, sense of soon, they had a transplant 11 months ago. Now, for the sake of the statistics of the surgeon, it makes a surprisingly big difference whether that transplant patient lasts a year. And we would like to think that would not affect treatment decisions, but it turns out it frequently does. So the surgeon is telling the family that the patient might improve their quality, might still get an uptick in quality of life. But you, and in this case, I'm assuming you're the nurse, are fairly confident that's at best overly optimistic, possibly an outright lie. But you are constrained by institutional policies not to give your own prognosis because that is outside your scope of practice. This is more frequent than I thought. Again, I've now seen it multiple times. I assumed it was just like one bad actor. I'd never hear from it again. And I keep seeing it and it's stressing me out. Okay, this is probably the most common. Your unit is just incredibly understaffed. You don't have enough time to provide appropriate care. This happens to literally, I think, 98% of the nurses I talk to. And yeah, this is a problem. Maybe it's not more frequent than you'd think. Maybe this is something you would have expected to be common, but it is very, and you know, in some sense, what you should do. You know the standard of care you should be providing, and you can't do it. Okay, so those are the cases. And what I want to know is, are the first 3 and the second 3 instances of the same kind of case, or are they different? So what do I mean by that? So cases in part 1, you're trying to decide what to do, are generally classed as moral dilemmas. What should you do? Notice that in the second 3, and I'm curious how many people detected a shift, or if you think there wasn't a shift, are generally classified as cases of moral distress, where you know what to do, but something is preventing you from doing it. An institutional policy, a scope of practice, there's some sort of problem. One thing everyone agrees on, these are both really not fun situations to be in. But what I want to know is, are they the same kind of no fun? Are moral dilemmas and moral distress, how are they related? Should we group them together? Should we split them apart? And I'm going to do two more cases. Sorry for the case overload. But these two are used by, I always hate to say philosophers' names because I'm afraid I'll get them wrong. That happened to me in a job talk once, but I'll do my best. Florey and Jameson, they're originally cases from Jameson, who introduced the notion of moral distress in the 80s. And it was then adapted in 2015, 2014, when the argument was made that Jameson misunderstood their own cases, and that what they thought were two different things were really the same thing, or at least variants of the same thing. So Jameson gives cases of what he says are moral distress and what he says are moral dilemmas. So in the moral distress case that is given, severely ill infant is in neonatal, this is a quote, intensive care and has poor prospects for a normal life and is most likely to be severely retarded. That's how they spoke then. Bedridden and in chronic pain. In some similar cases, infants have been taken off the respirator and allowed to die. However, in this case, the parents do not seem to understand the situation and the physicians pursue aggressive treatment. Here's the critical part. The nurse has to perform treatments which are very painful to the infant and which he would not perform if it were up to him. So this is supposed to be a case of moral distress and not a moral dilemma because the nurse knows the right answer. And the locution here is the terminology here is a little tricky. They usually use knowledge talk. You might wonder, does that imply that the nurse is right? Because knowledge is usually taken to be factive. So I'm just going to talk certainty. Is that factive? I can't find the right word. Something like incredibly high credence or maybe sureness. The nurse is sure of what the right answer is. These painful treatments should not be performed. And that is contrasted to the other type of case, which again is a moral dilemma. The details of this one are less relevant. It's the sort of thing where you have a clash between autonomy and supporting well-being. It's the moral distress case I'm really going to want to focus on, where there's an issue, there's an argument, the nurse is sure of the right answer, again, not assuming that's factive, but cannot do it. Okay, so what's my objective? Took a while to get here. I want to know if moral distress as a concept includes cases of internal consternation where there's some sort of psychological issue like resolving a dilemma, or if it's really entirely about external constraints. And I just want to give you some of the issues, rapid fire questions as they occurred to me, just to give you a sense of where my thoughts were coming from and how they're related to philosophy of science. And then I'm going to give you some answers, and then I'm going to go back and actually tell you why I hope you agree those are the right answers. And the first thing I wondered about in a philosophy of science context was how we should think about the concept of moral distress and what it would mean to say that it should evolve, because the original only included cases of constraint, where the nurse knew the right thing to do but couldn't do them. Should it evolve to include moral dilemmas? And this is where I started seeing work being done here and other places on this idea of open texture concepts, which has been used a few different ways in the literature. I mentioned my advisor was Stuart Shapiro, who writes about vagueness. He uses open texture synchronically to talk about concepts whose extension can shift in kind of real time as you like apply a vague predicate. Sometimes this person's bald, sometimes they're not bald. The more recent stuff that's been done here usually focuses on a diachronic notion and the way in which the same concept, when faced with something, a new case, a new thought, a new argument, we can see that it's not clear how to continue the concept forward. We face a choice, we have to use that choice. We have to make that choice. That's an open texture concept. As I'm going to use it, the sort of newer version, unclear if it's newer, might be Weissman's original version, I don't know. But that version is the one I want to talk about. How do we make these sorts of conceptual choices? And specifically, was moral distress, the argument's been made that all concepts are in some way open texture, but was this an instance of an open texture concept that was in some ways created in the 80s, and then did it properly evolve in the 2010s? Which I think is a little different from some of the types of cases you see, in that it really, moral distress didn't seem to, like, there was moral distress, but the concept moral distress didn't seem to exist before then. So it's not like temperature gradually figuring out, okay, is this heat? Is it, I don't know. This is, I think, we could see this much quicker in real time, and there might be different constraints. So specifically, I also wondered, does the split version of moral distress, by which I mean the version that treats moral distress and moral constraints and dilemmas separately, do those each pick out a kind? And specifically, does the notion that's just determined in terms of constraints pick out a kind? Or does the lumpy version that includes both constraints and dilemmas under the same concept? And since then, it's not just constraints and dilemmas. Since Foreign, we've had just sort of a proliferation of articles on moral distress. So one of the relatively recent ones talked about basically any psychological distress that's morally adjacent. It just, the term keeps expanding and including new things. And I'm going to argue that's probably a mistake for practical and theoretical reasons. You then might wonder, okay, you want to figure out if it's a kind, what is a real kind? I'm not going to answer that. Just a sneak preview there. Then you might wonder about, can psychological states like moral distress be real kinds at all? And probably. If they can be kinds, this is actually going to be potentially a little important, since I think they are. Are they individuated by their content as psychological states? Are they individuated, at least potentially in part, by their ideology, what caused them? Is there some sort of cool combo there? Okay, so now I'm just going to give you the answers, and then I'm going to go back to explain them. Okay, so I think how the psychological states can be real kinds. And a lot of these ideas on kindness of psychological states, I'm borrowing or co-opting from Khalidi. Probably, whether or not this was his intent, I don't know. But he thinks they are. I think he's right. I think they could be real kinds. If I have this on a later slide, it should have been here. To the extent that minds are real and minds have states, why not? And we'll see examples where they're individuated both based on their content and on their causes, potentially in conjunction. I already told you, I'm not going to tell you what a real kind is. It probably has something to do with causal linkages, mechanisms. We'll talk a little bit about homeostatic property clusters in a minute, and maybe usefulness. Okay, what I really wanted, what started me down this, does the split version of moral distress pick out a kind? I think it does. I think the notion of moral distress that focuses on external constraints importantly picks out a real kind in the world, and the lumpy version doesn't add anything significant to it. And then we'll talk a little bit about open texture, because I'm actually going to argue that this might look like a case of standard open textural evolution, but it's not. It was just a mistake to try and shift from the old version of moral distress to the new one. Okay, so I've already talked about this, but just to have it on the slides. So moral distress, originally proposed by Jameson as a phenomenon whereby nurses knew the right action, but were prevented from doing so by external constraints, institutional policies, physicians' orders, and such. This was later expanded to other providers and professions. That seems fair. If nurses can experience moral distress, why not others? So it is still a largely nursing phenomenon, because nurses are very frequently put in morally fraught situations, and they're frequently done so in those situations in a position where they don't have the power to do what they think is right, in a way that a physician might be faced with less, and like the president of an insurance company, even less so, because they can actually do things that affect those policies. The critical shift is that Forey suggested that the original concept was confused or confusing, and rather because it confused the cause of the distress, of the psychological distress with the psychological state itself, and that psychological state can be brought about by either constraints or uncertainty, and that this is just a mistake. But weirdly, he acknowledged, like, obviously there's a difference, like constraints and uncertainty aren't the same thing. So he then coined the terms, or they then coined the terms, constraint distress and uncertainty distress. So we still had the distinction between what I would have thought were two different kinds of things, but he's making them subkinds, or they're making them subkinds. I don't know what pronouns for uses. And since then, there's been an absolute explosion of literature on moral distress in the last 10 years. You can contact me for the reference slide. There's a lot of them. Okay, you might be wondering, does any of this matter? Whether we have one concept, two concepts, one or three concepts, I guess, one kind or one kind, or two kinds, or a kind and a subkind. I think it does. You might think if Fourier is willing to keep constraint distress and as its own subkind, and uncertainty distress as its own subkind, we can still translate, and that's true. So I don't know for sure this makes a difference, but I do think there are some reasons we should settle this. Some of them are practical. Moral distress is should be a critical notion in nursing education because it affects so many nurses. Again, you can see the literature on that. So it would be good if we knew what we were talking about in some sense. And this has been highly overlooked in nursing education. For one thing, it's just not as fun as teaching moral dilemmas, like trolley problems, yay. You might get screwed and not be able to help your patient, less fun. And there's nothing you can do about it, but you should be aware that's the thing that's going to happen to you, like not as fun of an ethics conversation. So there is literature that this has been under-explained in nursing education, so we need to increase its prevalence in nursing education, and while we're doing that, we should do it correctly. There's also a growing notion, well, I said there's nothing you can do about it, but maybe there should be moral distress consults. And what should those be doing? And I think what they should be doing should have some difference with what ethics committees do. Whereas if we start blurring constraints and dilemma, that kind of goes away. But in any event, if we're going to have moral distress consults, like when do we call them, is I think a worthwhile question. I think there are other benefits to keeping things split, which I'll discuss, just very pragmatic benefits of focusing on moral distress as a matter exclusively or almost exclusively of external constraints, keeping you from doing the thing you know you should do. So those are the practical reasons I think this question matters. There are also theoretical reasons. Practicing nursing researchers seem to think it matters, and in general, I tend to take practicing ex-researchers at their word. So if they think this is a worthwhile concept to look into empirically, and we can talk about how they've done that, then it would be good if those of us who are in that world and in this world can try and think critically about what exactly we're empirically looking at. And personally, I always think it's just fun to do some conceptual engineering. This is the classic, you make a few distinctions, you clarify a few concepts, it's a living. I just think this is nice to be clear on how we speak. Sort of anything that can be said clearly. I know I'm taking that out of context, but okay. Let's get to psychological states. As I said, I think they clearly can be kinds. You might wonder, maybe they're not natural kinds because they're in some way mind dependent. There was a really important observation, or at least I found it important in the book on cognitive ontology, which is that while natural kind, the term might imply not mind dependent, that term might just be not what we should be using. Apparently, and I just thought this was super interesting. This might have been an accidental invention of Venn misquoting Mill, who just talked about kinds. And the word natural just got thrown in there, seemingly by mistake, because he said he was attributing it to Mill, and it's not in there. So I think that's fun. Minds we can talk about. They seem to be real. Psychological states seem like perfectly good categories to be real as well. Now, Edward mentioned I did some work in a cognitive psychology lab. One of the things we looked at was the nature of psychological kinds, and specifically how psychological disorders and psychiatric disorders, as they're grouped in the DSM-5, which is in this country what is primarily used as the official diagnostic manual for psychiatric and psychological disorders. And it uses clusters of symptoms primarily. Check these boxes. If you check 3 boxes from this list and 2 boxes from this list, and it's harmful, that's thrown in there, which is an interesting fact that, yeah, we can talk about later, then it's a psychological disorder. And I think it does an okay job of picking out kinds. Major depressive disorder seems to be a kind, generalized anxiety disorder, etc. It does an okay job. I have some issues with its methodology, but it does okay. And we can treat these as kinds, things like major depressive disorder. I don't need to give you a full theory of kindness. This is classically something Socrates messed up repeatedly. I don't need to be able to specify necessary and sufficient conditions to know that depression or major depressive disorder is a kind without being able to give you its form or whatever. Now, critically, if syndromes, which is what they're sometimes called, without common causes or mechanisms can be kinds, I think if we can find something and say, this is the mechanism that causes it, this is the, or that sustains it, this is the cause, all the more so is that fairly clearly a real thing. And the type of, the specific one, and there are other examples I could use, but I think this is the clearest, of a psychological kind that I want to talk about is post-traumatic stress disorder. And this is just straight from the DSM. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. The details I could skip. And then it also requires presence of one or more of the following intrusion symptoms associated with the traumatic events beginning when they occurred. Now, one thing I also want to note here is that condition A seems to be de re. It's not that you think something traumatic happened, at least the way it's stated. It actually refers to a specific cause. Something traumatic happened to you. So the psychological state is individuated, if the DSM is right, both by what its content and by its vintage, where it comes from, I don't know the right word, origin, etiology. Okay, so again, central question of this talk, should constraint distress and indecision distress be part of the same kind or treated differently? And again, this felt to me like a lumping versus splitting debate, which is why I thought this was a good venue for it, in addition to the ethical implications. And I think there are 2 different ways we could argue for splitting the kinds up. So first of all, there could be practical considerations. They're the same kind in some sense, but we should treat them differently. So let's just talk about moral distress and constraint satisfaction as its own thing, and constraint distress as its own thing. If they're different kinds, we should obviously split them up. What's crucial, if they're the same kind and there are practical reasons to treat them that way, then Forey's right, we should go with that. I do think there's an asymmetry. I don't think there's any motivation for saying they're the same, they're in some sense ontologically the same kind, but we have motivation to, based on practicalities or conventional reasons, split them up. You might think there's no such thing as kinds. I'm sympathetic to that. At the very least, then, we don't have to worry about having moral, then I think probably, since we do have to have something like a moral distress consult, we should fall back on what's useful without worrying about the ontology at all. Yeah, so I think there are different routes to victory for the splitting condition. All right, so let's look at, should they really be the same kind ontologically? And this is the part of the talk that I would give here that I wouldn't give necessarily in a nursing venue. A lot of this that applies to. So let's look at the HPC, homeostatic property cluster, account of kinds. I'm thinking of Craver here in the 90s, late 90s, I don't know. Had sort of one of the seminal pieces explaining the pros and cons of this. So how do we know if we have a kind? Let's look at if there are properties that go together, have the same effect, are sustained by the same mechanism, I think. And again, this is more other people's fields than mine. Do constraint distress I'm just going to use Fourier's language, and indecision distress have the same result? I don't think so. If you have a dilemma, you might be able to solve it, assuming it's not a genuine dilemma, which I'll talk about in just a second. If you have the way we normally speak of a dilemma in common parlance, you have two decisions, two courses of action, it's really hard. You do an ethics committee, you talk to people, you might be able to find the right course of action. If you have a moral consult, if you have a moral distress situation in the sense of a constraint, sort of by definition, you can't do anything about it. If you could do anything about it, it wouldn't really be moral distress. You're already constrained. Or at least if you do something about it, you do it in a very different way. And specifically, you would do a moral consult service to maybe help you with communication skills versus consulting an ethics committee. So there are different paths you can take. So they have very different effect profiles. Same way you could take an ethics class that can help with moral dilemmas. I think moral distress, you probably want something like communication training, organizational management. They don't seem like property clusters at all. Forget the homeostatic aspect. But still, let's look at that. Do they have the same cause? No, this I actually got a little in my own head about, because my first thought is one of them, moral indecision, is based on moral judgment, whereas moral distress is based on, or constraint distress is based on moral perception. And here's what I got in my own head. I started wondering about, like, what about Jonathan Haidt, about how really moral judgment is a type of moral perception. And then I started wondering about Hume, about how moral judgment might really just be perception run amok. And I got really confused. And then I realized none of this mattered. Because definitionally, they don't have the same cause, because constraint distress is caused by constraints and indecision isn't. So this was actually much easier than I made it out to be. So we can just move on. And this involves not just homeostatic property cluster accounts of kindhood, but anything that has to do with same causes. By definition, these are different causes. Is there the same mechanism holding properties together? Well, when the properties are so different, this question almost becomes moot. And even if you could find, and I think this is, if Fourier says, look, there's the same mental mechanism at work, if it's got different causes activating it, and most important, and if it does very different things, this isn't a homeostatic property cluster, it's not a kind. And one example I thought of, I'm sure there are better ones in the literature, like a spring is a mechanism. That doesn't make a mousetrap and a slinky the same kind of thing, just because they have the same mechanism underlying them. So I think this doesn't matter. So that's, once I was doing this, well, that's how I think about kinds in sort of an HPC way. We could think about them in other ways. If you want to talk about essentialism, where we have necessary and sufficient conditions from on high. Sorry, this is a bit of a caricature. Well, the part of the question is, what should those necessary and sufficient conditions be? This just kicks the can of how we should define moral distress back a level. I think conventionalism is the other. So I'm not super sympathetic to essentialism. I also see the pull of conventionalism a lot. That kinds we just define as useful. This seems to collapse to the question of whether we should treat them the same or different. The ontology collapses into the utility question, or differently, and that determines this kind status. And honestly, this could have saved us a lot of time if this is the correct account of kinds, because this points us to what I think is the question that I would focus on in other contexts, which I think is the important question, which is, what's the most useful way to think about this? And I think this brings us to the question, sorry, I happen to be reading some 6th century Jewish texts, and so I was picking up some cool Aramaic words, and they have a word for just like, okay, let's just get to the actual matter here, which is gufa, which I really liked. There's going to be one more later that I like more. And I think we should treat them differently, which I think is, we should, as a practical matter, treat constraint, distress, and indecision distress differently. And I think there's a very good practical reason for doing so. Again, I pointed out different remedies, but more importantly, I think there's almost a socio-political aspect here, which is if we talk about like, oh, there are all these ethical problems that befall nurses, and they're all in moral distress, including internal issues like consternation or indecision, that makes it sound like it's the nurse's problem. And I really think what the original concept did, and what I think is a useful thing to do, is put the burden on the institutions. Why are you setting up these policies in a way that your nurses can't do the right thing, what they are sure is right? Why are you setting it up this way? Yeah, and I almost think it alleviates a form of epistemic injustice, which you're probably all familiar with, so I'm not going to go into because you understand it better than I do. But if you say that the problem is, oh, the nurse doesn't know what to do, that's of a piece with the nurse being prevented from doing what they're sure is right. I think that silences, I could be wrong about this, I think that somewhat silences the nurse's voice. What the problem is that we're silencing the nurse's voice in being able to say the right thing to do, and we should focus on that by focusing on the constraints. Okay, this is another piece I wouldn't do in other places, but for those of you, if you've ever looked at my account of understanding, which has to do with we understand something better when we encode the information so that we can reach more practical upshots with less information, more compressed information. I just think that having moral distress as an overarching category, and having constraint distress, and having indecision distress is inefficient. It just forces us to encode an extra step. Now you might be wondering here, well, is this always an argument for splitting concepts more narrowly, that as soon as you have a superordinate concept, you have to remember one more thing? And that seems like that would be bad, because sometimes it makes sense to group concepts together. But I think there is the debate should be, does the superordinate concept do work? Which again, gets back to the matter itself, which is what's the practical way to be talking about this? And in this case, since I don't think it does important work, we're better off splitting. So now we get to I've been giving you one side pretty consistently. Now I'm going to give you why should we treat them as the same. And these are just taken straight from the 2015, which is then cited by other things, which cite that, and you get this whole tree, and it all seems to come back to these few arguments. And I don't think they're good. So the argument is that Jameston's definition runs together the cause of the distress, i.e. the constraint, and the distress itself as a psychological phenomenon, and that's for some reason bad, because psychological states are content-based and causes are causes, but I just think that's not true. We've seen that's not true with PTSD, which is why I picked that example. Psychological states, like many things, can be individuated in part by their etiology. So that by itself is I don't think a good objection. Okay. So what else do we have? Okay, Jameson just differentiates. These are just arguments straight from the 2015. Jameson just differentiates moral distress from genuine dilemmas. So when Jameson's arguing that moral distress can't include what we think of as moral dilemmas, that really only has to do with genuine dilemmas. But really, what we should be thinking about is moral conflict. So a genuine dilemma is where you really cannot there is no right thing you can do. Whatever you pick is wrong. Think of your start example of going to fight the Nazis versus taking care of your ill mother. Sure, maybe Jameson has something to say about those. I think that's not the right way to read Jameson, because no one but philosophers cares about genuine dilemmas, I don't think. I just don't think that's a thing. There might not even be any genuine dilemmas, even among philosophers. So I just don't think that's what he could be talking about. Okay, so let's focus on distinguishing let's just put the genuine dilemma aside to talk. I think it was a red herring. We could talk more about how Fourier uses it, but I don't think it helps. So, okay, the examples Jameson uses, and this is why I wanted to give the exact examples, do involve moral conflict. So if you remember the original example of moral distress from the Jameson quoted in the Fourier was, starts with, they don't know what to do. They reach different decisions. The nurse thinks is sure of what the right solution is, but he can't do it. And here I think the moral conflict comes before the distress. The distress only occurs after the judgment has been made. And we can go back to the case. And the critical thing is that I don't think there's anything in any of the cases that shows that conflict is actually a part of the distress itself and not just a precursor that sometimes comes, and that we could get the same phenomenon that Jameson wants to talk about without ever mentioning moral conflict. So I don't think it's necessary to do so, which is what Forey needs for his argument here. And more specifically, the examples always have to do with moral disagreement, which involves conflict. That these are part of the same argument. And I think this is true of most more real examples. Because usually if there's something preventing a nurse from doing something, it's because someone disagrees it should be done. So in most cases of genuine moral distress in the real world, there was probably a moral conflict somewhere upstream. But I don't think there has to have been. Forey's arguing there has to be, and that's why dilemmas and constraints are inextricably linked. And so they should be part of the same kind. I don't think they have to be. And we can see occasionally the result of policies that aren't really based on moral disagreement, but just based on rigid policies that lead to cases of moral distress. So suppose you have a case, this is also real. So most hospitals, so suppose someone comes in having an allergic reaction, they have hives, you're not sure, the doctor's not sure if they have anaphylaxis. So you want to observe them for say 2 to 4 hours. There's about to be a shift change. So the night shift's about to come in. They don't usually discharge patients at night. So that patient is admitted for the entire night for observation. Let's say 5 hours later, the parents ask you, kid looks totally fine. The parents ask the nurse point blank, is it actually medically necessary for us to stay the night? So they have somewhere to be. I don't know. People have things to do. By policy, the nurse has to evade the question, say they can't answer. They definitely can't say, yeah, you can go. Even though you might think veracity, which is generally thought to be a moral principle, might suggest they should at least indicate that. It's a policy that makes sense. For various reasons, it's important not to have people leaving in the middle of the night. But there's no real moral disagreement here, but there is a moral constraint. It is a case of moral distress, I think. So they don't have to go together, and I think there are good reasons to keep them apart. Okay, now whenever you have a lumping versus splitting debate, you might think parsimony would suggest, well, why would we have two kinds, moral distress and moral dilemmas, when we could just have super moral distress, and it'll cover both. So maybe parsimony suggests we should only have one thing when we can really, instead of two. Although again, even when we have one thing, if you're keeping the notion of constraint distress, we really have three things anyways to keep track of. And this gets to issues that you all might be aware of about trying to parse how many things we have, how to actually apply parsimony. If we have a kind and two subkinds, have we really achieved parsimony? Then you have to wonder about questions about if you're using something like Occam's razor, is your goal to have the fewest number of things, which is probably how it was originally intended. Maybe, so maybe you have fewer things here because you only have one kind instead of two. But I've always thought that's a weird way to use Occam's razor anyway. One of the great examples that it's better to think of it as people actually do use it more in terms of we should have simpler explanations. We should favor simpler explanations. One, we have to do that anyway. Two, if you look I got convinced of this once that this was a better way to think about parsimony in a mereology class. That if you're just counting things in the universe and trying to minimize them, there's no such thing as tables because we can get by with subatomic particles. And it's just a really weird universe to always have to be quasi-realist about tables. That's just a weird ontology. But in any event, I don't think parsimony is going to be the deciding factor here. And I think this is my favorite Aramaic word. I think we're just done. This is I think Forey had arguments that he thought, and maybe I'm not representing them correctly, but I think I was, that dilemmas had to be inextricably linked to distress, and so we should treat them as the same kind. That was argument number one, or I did the second order. Number two, that really the nature of a psychological kind is individuated entirely by its content, and I think that's just false. So I think the arguments on which this entire edifice of treating moral distress as potentially involving dilemmas is just not based on solid arguments. And I think there are very practical reasons. It puts too much burden on nurses to start talking about, oh, you're under stress. It makes it sound like it's their problem. And I think that's not just bad philosophy. I think it's actively dangerous. And to be clear, the arguments for lumping are explicitly presented as philosophical and conceptual. Like, he uses the words conceptual analysis. So I'm like, okay, this is fair game for going through and thinking about the concept. And is it true that I mean, I'm not just taking a philosopher of science's fight to a nurse's journal. This is the game he wanted to play. And I don't think it holds up on those terms. What do I go to on? Anytime between now and one. Okay, I do want to mention open texture again in the next 5 minutes. Because again, this is the right crowd for it, so why not? What would have triggered conceptual evolution in this case, such that we might consider it a case of this is just what concepts do. You started off with it thinking it was just constraints, but then we thought of something new, and now we realized it wasn't. But there was nothing new. There was no new event. There was some empirical work about where they would ask people about how they felt at their jobs, but all the interesting work about defining moral distress was done in, the introduction, where they defined moral distress. So there wasn't actually good measurement. There wasn't actually good calibration of what they were measuring. Maybe it was just reconceptualization based on old data or a new theoretical insight. We thought we had a good concept, but we thought about it more, and we realized we didn't. So you can think of, thought experiment. Maybe we had this cool thought experiment. There wasn't one. I don't see what could have properly triggered this. You might think, well, sometimes even just looking at the same data, you could realize that you weren't appreciating its implications. So when Count Rumford went to see how cannonballs were drilled, and you noticed that they were getting hotter than could be made sense of on caloric, this is something we're all familiar with, but now I've realized that our concept of caloric is bad. Nothing like that here. So I think what there has to be is reconceptualization based on a new idea. But what if it was just a new thought based on bad arguments? Then that's not a reason to evolve our concept. And so the thought, as I understand it with open texture, is how do we evolve our disputed concepts? Which makes me wonder what makes a concept disputed. Does the fact that someone disputes a concept entail that it's disputed? That's obviously wrong. Do we go by number of people who dispute it? Does it have to do with what's going on in textbooks? I don't know the answer to these questions. I also think there are political implications for what counts as disputed. But it seems like just the fact that someone disputes something doesn't make it a legitimately disputed concept. So I want to finish. Again, I still have a couple minutes left on open texture because I think it's interesting. So this is straight from Deon's paper. So here is what he thinks about open texture is. These are not necessarily necessary conditions, but they're supposed to be important. Is a property of our concept such that in situations where the circumstances demand that we standardize our use of language, a single object or novelty can give rise to at least two comparably reasonable but conflicting ways of classifying and thereby highlighting a previously unconsidered indeterminacy. That's how we know when we have an open texture case where we should evolve our concept in one way or the other, because we have to. There are two reasonable alternatives, and there was some novelty that gave rise to it. But yeah, these were not intended as necessary conditions. I know because I asked. but they were intended to be important and potentially necessary, or intentionally, I mean, jointly, they should indicate what an open texture is and when we should evolve our concepts. Do the circumstances demand here that we change? I don't think so. What we had was working fine. But more importantly, that's I'm not sure about. I don't think there was anything novel. That's what I just argued. Or didn't argue, but I can't think of what it would be. And I don't think they're comparably reasonable, because I think thinking of moral distress in terms of constraints has more practical upside, and thinking of it in terms of, and the advantages of thinking of it as of a piece with moral dilemmas was motivated by insufficient argumentation. Now that said, last point I'm going to make, I have 2 minutes, it's perfect, is that you might think sometimes bad arguments win, and that's just life. And that's true. So the arguments for making Pluto not a planet, but keeping Earth a planet, because you can make really good arguments that Earth also isn't a planet, because we also have something that we didn't clear our orbit, which is kind of cool if we end up with a concept of planet that doesn't include Earth. But I'm told that the ability to make Pluto a different category than Earth was based on bad arguments. I'm not an astronomer, I don't know that's true, but so I have been told. But the concept changed anyway. So maybe moral distress is like that. And that even though it shouldn't, but I don't think we're at that point yet. There are still people who hold to the Jameson definition. There's still literature reviews that just give large tables. Here's 30 things moral distress can be. I think we're at the point where, we're in the astronomers' conference voting about what Pluto should be. So I'd rather not give up on a useful, practical concept yet in favor of something muddier and more diluted when we can still vote the right way. Okay, and I think I timed out exactly, so let's do it.
I think I should take a tea break for coffee and refresh yourself, 2-3 minutes, and then we can open for questions.